Nobody's in yet. There we are. Welcome, everyone. Got a number of folks filing in. We'll just give folks another moment or two before we get started. Welcome, 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 welcome. A bunch of people still filing in. Another 20 seconds or so, and we'll get underway. All right, so 30 of my relatives have logged in, so I guess we can probably get started. Hey, everybody, good afternoon. My name's Dave Hiltz, and I'm serving as the host for your Citizen CPR Foundation Champions webinar today. And on behalf of the foundation, I wanted to welcome you and thank you for taking time out of your busy schedule to participate in what I believe is going to be an excellent discussion with some very passionate physicians who are also enormously talented around the subject of primary and secondary prevention and disparities in cardiovascular health. So we're going to get to them in a few moments, but I did want to go through a few housekeeping items and make a few comments before we get underway. So for the repeat offenders on the webinar, you're aware of the Citizen CPR Foundation mission. And, I'd point out these three items. We know that CPR and AED utilization makes a significant impact on survival outcomes. We know emphatically that collaboration among citizens and professionals and others in the community is key to enhancing survival from sudden cardiac arrest. And we also know that action based on best practices in science, education, and implementation will also improve outcomes. So I'd like to recognize the support from our partners at the Citizen CPR Foundation. Without the support of these incredible organizations, we would not be able to make any progress in addressing our mission, nor would this webinar be possible. So thank you for your ongoing support. A quick reminder to the group, always happy to make announcements regarding your conferences, webinars, initiatives, or other campaigns. Please communicate with me in advance, and I will be happy to let others know about what you are up to. So on that same note, I'd like to remind everyone to save the date for the Citizen CPR Cardiac Arrest Survival Summit in San Diego, December 7th through 10th. But more time sensitive at this moment is, if you've got a great idea or an innovation or a reflection on science that you think is worthy of sharing with others, we want to hear from you. So you've got a little less than a week to put together your abstract for submission with the Citizen CPR Foundation. So day after Valentine's Day, please get your abstracts in. As a reminder, your microphones will be muted. Please use the chat function to capture your questions. We are very hopeful that we'll have a lively question and answer period, but this is very much dependent on your submitting questions for us to answer. So please capture those using your chat function as we move on. Now, some of you may have seen some of the social media promotions that we did. You may have wondered, what was David thinking about with this particular image? And so, I'm thinking about primary and secondary prevention, and we want to keep the population healthy, right? So we want to keep them healthy, and part of that is, steering them clear of disease, but then identifying disease very early on, right? So I see this as, when somebody's been identified, they get on this kind of escalator, right? And the escalator is slowly progressing towards acute event, right? Your STEMI, your cardiac arrest, your acute stroke. And so we want to influence these people in the speed by which this escalator is carrying them closer and closer to having an acute event, right? And then, for anyone who's been to the Grand Canyon with their family, and, my wife repeatedly saying, get back from the edge, get back from the edge, get back from the edge. Those of us who are involved in rescue and healthcare, when we see somebody near the edge, what do you want to do? You want to tell them, stand back from the edge. Or if they're starting to lose their footing, right? You're going to reach out and you're going to grab them by the back of the shirt or by the belt, and you're going to pull them back from the edge of the cliff, right? So I'm thinking EHAC education, stroke education there. But when we fail, and ultimately some of these people on the escalator going up are going to fall. And this is where we live typically in HEARTSafe communities. Most of us on the call, except for the friends of our guests, are probably very focused on this acute event phase of things. And we don't think much about this end of the story. So we've got some really incredible guests to talk about this, far more lucidly than I could ever imagine. And so I just wanted to do a personal call out to my good friend Laura Saul and Nancy Brown, the CEO of the American Heart Association, for providing us with our incredible guests this afternoon. So thank you, thank you, thank you. And Mallory, would you please go ahead and roll Nancy Brown's video for us, please?
Thank you for joining us today. I'm Nancy Brown, Chief Executive Officer of the American Heart Association. We are so proud to partner with the Citizen CPR Foundation on our shared commitment to improving survival rates from out-of-hospital cardiac arrest. As resuscitation leaders in your communities, each of you bring this mission to life every day, and we thank you so much. American Heart Month is the perfect time to focus on prevention, looking upstream at wellness and education for preventing a cardiac arrest from occurring in the first place. Throughout February, Go Red for Women spotlights how heart disease and stroke uniquely impact women and disparities that exist, such as AHA research that shows that women are less likely than men to receive bystander CPR. Now I have the pleasure of introducing two phenomenal volunteer leaders who will address these important topics. A great friend to the AHA and to me personally, Dr. Stacy Rosen, is a pioneer in women's health and an inspiring force behind the Go Red for Women movement. Dr. Rosen is a former national board member and currently serves as president of our Eastern States region. She is a cardiologist, author, speaker, and senior vice president of women's health at the Katz Institute for Women's Health in Queens. She is a Partners Council Professor of Women's Health and Cardiology at the Zucker School of Medicine and a Fellow of the American Heart Association. We are also delighted to have Dr. Pavitra Kotini-Shaw with us today from the University of Illinois at Chicago, where she is Assistant Professor of Emergency Medicine. She is fellowship trained in ultrasound and resuscitation and has a special interest in improving outcomes for cardiovascular emergencies. Dr. Shaw's work includes multiple grants to explore racial, ethnic, and gender disparities. As a Birch Scholar, she's studying how sex as a biological variable contributes to heart disease and gender-specific resuscitation approaches to improve survival outcomes for both women and men. Her research on disparities in out-of-hospital cardiac arrest is fascinating and so relevant to today's conversation. I hope you'll join me in welcoming Dr. Rosen and Dr. Kotini-Shaw. And now, David, I'll kick it back to you. Thank you.
Wow, that was terrific. Nancy, wherever you are, thank you. And, some of you on the call know me and you know that I can get talking sometimes. So, good news is I'm going to try to be mindful of the time. So, we do have a sense for what we're going to be talking about this afternoon. And again, thank you so much to our two physician guests, Stacy and Pavitra, for their willingness to join us this afternoon. So I've got a couple of questions, and I'm not going to direct them at either one of you. So I'm going to ask that you step forward and provide response, and then we'll give your peer response opportunity as well. So here we go. Let's get started. We hear and know that an ounce of prevention is worth a pound of cure. Uh, can you provide us with some easy to understand examples of primary and secondary prevention in terms of cardiovascular disease? Please.
Sure. I guess I'll start, Pavitra, and then we
Right,
could
Stacy.
bring it together. What's most fascinating, I've been practicing cardiology for almost 30 years. And, our research, our clinical practice, our community initiatives were focused on preventing death and disability from heart disease and stroke. And we have evolved from that to preventing heart disease and stroke. And then ultimately, with the American Heart Association's new focus and mission statement, to really looking at how we can best improve holistic overall well-being. And it starts at every age. We know that the things that cause heart disease and stroke are 80% preventable. And we know that they start in our teens. So it's sort of never too early. We look at something like hypertension, which after cigarette smoking is probably the #1 preventable cause of vascular disease, heart attacks, stroke, kidney disorders, peripheral artery disease. And we know that that's something that with the right amount of science that comes to us from AHA, including gender and race and ethnicity focused science, the same medications, the same treatments don't work for everyone, and that's been a huge advance. We've learned with implementation science how we get into our communities to identify hypertension early, how to treat it, both as a preventative strategy to primarily prevent disease, that big crowd before the escalator, and then for those with secondary prevention. We can say the same about diabetes, cholesterol, inactivity, weight abnormalities or abnormal BMIs. So we know that these things have an impact. And what's also great is that we know that small, consistent steps have a tremendous impact. People think it's really hard to do these things, and we've learned that it's not.
Yeah. Wow. Excellent. So I'm seeing, the big bad boys, tobacco, hypertension, diabetes, which I, often refer to as, heart disease in disguise,
Mm.
physical inactivity, unmanaged cholesterol. Pretty safe summary, Stacy?
Yeah, yeah. And, in my practice, I don't use the word diet. I don't use the word exercise because then they sound like, curse words. These are, big, hard things that we don't like to do. And, the truth is we've discovered through science and much of it sponsored by the AHA that it's small steps and that this is doable. And
Yeah.
every one of us could make more right decisions every day to have an enormous impact.
So incremental small steps towards improving overall cardiovascular health and minimizing risk. Uh, Pavrita, would you be able to add additional comment? And before you
Yeah.
respond, could you give us a sense for how well we're actually doing? I mean, we're all working so hard to improve health and outcomes. How are we doing? Indulge.
Sure. Yeah, thank you for having me here, first of all. So, as an ER physician, as Nancy just mentioned, I trained in resuscitation. I did an extra fellowship. So, I came into my professional career essentially just focused on the worst case scenario, the cardiac arrest is the ultimate resuscitative event, right? But in my career span already, just within the past 5 years, there's been this paradigm shift in our thinking of from being reactive to being preventative. So myself and my colleagues here at U of I, we really embrace this notion of preventative emergency medicine. And so in addition to all the things that Dr. Rosen just mentioned, I would add to that in terms of primary prevention example, I would say, the one thing that's often overlooked is sleep. The need for sleep is something that's so critical, and we often lack awareness of it. We often curtail sleep for other activities all the time. So believe it or not, I commonly ask my patients in the ER how long they've slept. And as Dr. Rosen mentioned, it's sometimes these little things, little adjustments. So I sometimes have these conversations about, well, what can we do to minimize your disturbances around sleep so that you can get 7 to 8 hours of sleep ideally, because studies have definitely shown that when you have a short sleep duration, especially under 6 hours, that relates to increased hypertension and increased obesity and sleep apnea and all sorts of things. So those are some examples in terms of sleep.
Yeah, interesting. And you
Yeah.
bring up your background in resuscitation. I understand somebody told me that you've actually been to the Citizen CPR Foundation conference in the past, but it
Yeah.
brings back, I can't remember who it was or whether it's still around, but I remember some folks talking about cardiac arrest as like in the sense of a bow tie, right? With interesting that I'm wearing one with a cardiac arrest being the knot of the bow tie, right? But you've got, this large group of people on either ends of the bow, right? Pre-arrest, right? Opportunity to influence, change behavior, modify risk, and prevent them from arriving at the knot. And for those who do arrive at the knot and manage to survive the knot, what can we do on the opposite side of that knot to make sure that they don't slip backwards and have a second acute event? So very, very interesting. Um,
Yeah. I would just to answer your second part of the question, in terms of perspective on how we're doing, I have to say I have a little bit of a skewed perspective, right? Because all I see in the ER are people who are unable to prevent or delay these acute manifestations. And what I see and hear are a lot of the barriers that people are afraid to take their medications. People can't get in to see their primary care providers. But in doing just some of the background research, for this webinar, the AHA launched in 1997 this campaign for women, right? And since then, in a 12-hour or 12-year span, there was, because of the increased awareness, there was nearly a doubling of the rate of awareness in that 12-year span just from launching this kind of campaign. And then within that same time frame, there was nearly a decrease by half in the deaths related to CVD. So I think we're getting there. We've made progress, but I will say in my personal experience, I see a different perspective on a day-to-day basis.
Yeah, and I think there's more than a handful of us on the call who can appreciate your perspective. Hailing from the emergency department, very interesting insight from both of you, and actually, Pavitra, that's a perfect segue into kind of the next segment of our discussion, and that's, in what ways, I mean, we've all been affected by this global pandemic. But tell us a little bit, both of you, about how this has affected our collective efforts at improving cardiovascular health, reducing risk, helping people steer clear of acute events. Tell us a little bit more about what you're seeing from where you are in regards to the COVID effect, if I may.
Sure. I can start. So I have to say, so I've been very vocal, at least on, social media, about early on, a lot of our public health messaging of staying at home, was really misinterpreted as stay at home and don't seek care. That was not what it was meant to be. But unfortunately, we saw the implications of that messaging in our ERs, because some days there were nothing like it before. Like, our ERs were quiet like we've never seen, right? Because people were really afraid. And when I did see people, and I remember one woman vividly who was forced to come in at, by enforcement by her family to finally come in, and she said, I would much rather die at home, because she had a blood pressure over 200, but she made it. She came in, but she didn't want to stay, and she said she would much rather die at home than come to the hospital or stay in the hospital because of COVID. So there was some real fear in the community to really seek the help and to stick with their preventative, like appointments, their regular, appointments, to get their medications refilled. So it was, I think it's a challenge, and I'm curious what Dr. Rosen thinks, because I feel that, unfortunately, especially even particularly for women, there's been this disproportionate burden, right, on domestic and caregiving responsibilities, and compounded by financial and other adverse life events. And these impacts impact our mental well-being, which then leads downstream effects to, our immunological effects. And so these hard to measure, quantifiable and measurable factors may even halt or even reverse some of the progress that we've made in the past few decades. So I'm worried about that, about the downstream effects of COVID. Yeah.
Me too.
Yeah, I think we all are. Stacy, please.
Yeah, I'm going to just tag on to what Pravita said regarding, where we're going. It's the first time in the last couple of years that, despite all of our best efforts, we saw a plateau and then potentially a little bit of an uptick with regard to cardiovascular mortality and morbidity. And it speaks to some of the expansion in these general risk factors, the big bad guys, I think you called it, the increased prevalence of obesity and diabetes, poorly or inadequately treated hypertension is increasing in prevalence. That's impacting on Black women predominantly. Diabetes is especially potent in Latino women. And we're seeing that some of all of the good work that has been done through clinicians like us, Heart Association, research, this organization, we're afraid that we may be at a leveling off to almost an uptick. And then you put on top of that, you know, an unimaginable pandemic. If I have to ever say the word unprecedented again, I will just scream. It's just like, I don't think I've ever said it before compared to now. So you know, the points that Pavitra brought up are exactly that. You know, we have people who are avoiding hospitals, and, you know, the Heart Association campaign, Don't Die from Doubt, I think is fabulous. And every time I see patients, even when we were doing complete telehealth, and I practice in New York, so we were, you know, totally locked down for our ambulatory practices. And I reminded people that you are best off in an emergency department in a hospital if you have a God forbid. And in New York, we saw a drop in the rate of strokes and heart attacks. And we know that didn't really happen. I think it also brought impact the fact that it was harder to get fresh fruits and vegetables. It was harder to walk outdoors. It was harder to keep track of your medications. I wholeheartedly agree, and the data is there, that women bore the brunt of, you know, 2 jobs, 3 jobs, you know, et cetera. More dropped out of the workforce, which impacted on families, you know, economic status. And then finally, we have the fact that COVID has an impact on heart function, as well as probably on vascular disease. There was a really fascinating article that describes the impact that the virus has on blood vessels. And that may be one of the explanations, that kidneys, lungs, brain, you know, virtually every organ in the body is involved. So, you know, even the obnoxious virus actually has had primary, you know, problems with regard to cardiovascular anatomy and physiology. So, you know, all in all, a very challenging year.
Yeah. And like a really kind of dark picture, you know what I mean? Um, you know, we're mindful that when a patient is affected, it's really the entire family. And I would suspect that this is particularly true with the females in our families. And you know, I'm hearing a number of other messages. You know, the issues around food deserts and the fact that some people would rather die from embarrassment, you know, rather than call an ambulance, right? You know, fear of rattling the neighbors and all these. It paints a very, very difficult scenario and story for us in the life-saving business to contend with. Pavitra, what say you? Please add to the story.
So yeah, absolutely. The challenges are enormous, but I think the way we have to address these differences that we see, these disparities we see, are, in my view, kind of 3 levels. There's the individual level, there's the provider level, and then there's the systems level. And that's how I try to kind of compartmentalize different approaches I think we can do. So, I mean, honestly, to keep it real, right? Like at an individual level, I think it requires a shift in the conversation from, you know, from let me tell you what you need to do because it's good for you, to a conversation about, you know, it's good for you and you want to do it because you care about yourself, and here, how are we going to make that happen, right? So I think that's where we know the statistics, we know that there are these great disparities, but it has to be this shift in, well, then how do we implement it that's meaningful, that's context specific for that patient? So I think that's what's needed kind of on an individual patient level mind shift. At an organization, or let me start with the provider level, I think at the provider level, there's so much education that needs to happen, even just around sex and gender, and racial inequities and differences. I mean, just the fact that we don't necessarily take these contexts when we look at commonly used risk stratification scores, and the fact that we use the typical screening tools for men and women when we know that women present differently. For instance, 40%, I believe, of women who've had clean heart caths come back to the ER with, chest pain. And I'm guilty of this too, because I just didn't know any better, that, they probably have some level of microvascular disease that is what's causing their symptomatology, but it goes undetected because we use the same traditional screening tools that aren't picking these things up. So we have a long way to go in terms of educating providers to really put each patient in their own context, and so that needs to be done. On a systems level, I think that's where, we have an opportunity to help provide the tools to change this conversation, to really talk about ways to implement changes at the community, on the household, on a day-to-day basis. And so I guess I'll just stop there before I start rambling, but I hope that provides some insight.
It's nice to know I'm not the only one. A number of salient points here. And, of course, this is a Heart Association kind of focused show today. But, I think of, Paul W. White, Dr. White, who, I think of his recommendations, he had lots of them, but it was like all afternoon should be basically allocated for recreation and physical activity. And, I ran that idea by the director of one of the emergency departments where I worked once upon a time. And, I think it fell on deaf ears. But, it's, again, that's how you change individual health, provider, knowledge capacity and literacy, and how to change the system. Man, these are big ticket items. And it would seem to me that even the American Heart Association, with all the things that they bring to the table, by themselves are not adequate to stand up to this significant challenge. So it calls on that, that collaboration note that is inherently true in virtually all things, but particularly around this particular subject. So with that said, I'd like to ask, because again, we're kind of progressing just as planned here, even though we didn't spend a whole lot of time planning. Certain segments of our population are clearly underserved, and there are significant disparities in regards to cardiovascular disease prevention, prevalence, and access to care, and then some. Could the two of you kind of speak to this subject, and how can we better understand this critical issue and do something about it?
Give it it sounds like a simple question, right? So the population health people have taught us that 80% of your ability to stay healthy as an individual, a family, a community goes on outside of a traditional healthcare environment, the emergency department, the doctor's office, the ORs, the hospitals. And what goes on in the 80% of our world is what really matters. And I think previously, both a paternalistic approach to medicine, as Pavitra said, I'm going to tell you what to do. We found that doesn't really work. And if we gave you a prescription, but we didn't explain it in a language that you're comfortable with, or that addressed social issues based on your religion or your ethnicity, then we were doing a bad thing, no matter how well our surgery went or how well our intervention or CPR went. So we know that we have to kind of get out in our communities. We have to evaluate social determinants of health. The Heart Association, it's at the very core of what all of us as volunteers do. And the dean of our medical school says that if there's no health equity, there's no health. So, the one size fits all, this is what we have, figure out what to do with it. I'm not a social worker, I'm a doctor, I can't deal with food insecurity or health literacy is ridiculous. And I think all of us in this space realize that collaboration, getting out of our silos, amplifying each other, convening these groups together can really allow us to, and they're not easy, but they are doable if we, respect each other's expertise, and we have the voice of the patient, community, family in the middle of it, so that it's not us experts telling people what to do to stay healthy.
So
Yeah,
a collective web of influence in the community almost at all levels.
yeah, I would say, like, practically speaking, right now during this pandemic, most of us who are going through a lot of stress and loss of life and despair, we lean on our either our friendship circles or our faith-based organizations, and it's that kind of collaboration between powerful resources like the AHA and our local leaders and our faith-based organizations to really continue to iterate and reiterate around these opportunities like Heart Month, and the next month is going to be a Diabetes Month, and to reinforce these concepts, how on a day-to-day basis these are critical changes that we can make. And then really, I personally like to advocate for having an accountability partner to really make that happen for you on an individual level.
Wow.
I took my mother last week, my 81-year-old healthy mother, to in Manhattan at the Javits Center, which is your traditional, massive auditorium, to get her second vaccine. And I saw the size of the place, the vast number of healthcare professionals, as well as military for logistics. And I thought, wow, what if this group could check blood pressure? What if this group could ask, do you have a primary care clinician? Just as an added sort of one-off. The state spends so much money on this site, and that's what I think we're both alluding to, that the alignment and amplification of resources will make these problems manageable. And just the fact that we talk about it, when in the old days it was, I specifically remember a very well-respected physician who I used to work for, who literally said, I'm not a social worker. It's not my, problem to manage where they get their pills, or, if there's food insecurity, but that's not the way we think any longer.
Yeah, and I'd like to start seeing, like employers to really incentivize. I mean, many people now have Fitbits and watches that track number of steps, to really incentivize a goal to have 10,000 steps a day or mental health days off. Those kind of policy changes would really help continue our progress.
Yeah, and don't forget our healthcare providers in those same changes, right? So really interesting, right? So we're among the worst. I think about my own sleeping habits when I spent 15 years working night shift in an emergency department. They were far from desirable. But it's really, I'm picking up on some really interesting verbiage that you're all using. I'm not a social worker, right? But what could I bet you, if we asked a social worker, what could you learn from a doctor, they'd probably say a great deal, right? But if we asked physicians, what could you learn from a social worker, we might not get the same kind of response. But at the same time, there's a lot we can learn from one another. And it brings to mind, I was doing a talk with some cardiologists, right, at a big conference. It was American College Cardiology, and one of the co-presenters was a probation officer, right? And I was like, "What is a probation officer doing on our group?" And he talked about, well, look at recidivism and those patients who, they've got a disease and we're trying to slow their progress, but they're not listening. And then the hospital becomes the jail. And, it was a very interesting take on how to slow people down on that elevator ride up to acute event. So fascinating discussion. I'm looking at the time and I want to save some time for the group to ask some questions. So I'd like to move on and say, most everyone on the call is familiar with the Go Red for Women movement and campaign. Um, I see that both of you, I think, are wearing red dress pins. Can you provide us with an update on the Go Red campaign and how's it changed? Because Laura gave me a little bit of insight, but I'd like to hear from the two of you.
Sure. The Go Red campaign started in 2004, predominantly as an awareness campaign. It was the concern that women didn't know their risk. And if women knew their risk, and they originally partnered with media and just to, know your numbers. And it has evolved extraordinarily. I mean, Go Red exists in over 50 countries. It is an international movement. It includes STEM Goes Red, with a new initiative over the last few years to bring high school age young women into science, technology, medicine. It has included Research Goes Red, a very unique partnership the AHA has with Verily to identify women who are willing to participate in research. Part of the challenge was even now to date, a recent study showed that of all the cardiac trials, they included only 36% women across the board. And for certain types of cardiac disease, the number's as low as 25%. And if you lump women in with men, we know you actually do a disservice to men as well as women. So these things are important. Almost $550 million spent on research, strategic research initiatives on women's health. So it has gone from a impactful and very unique awareness campaign to a full thickness research, professional education, international movement. The only thing before I finish is that what we are learning, though, and Pavitra said this, that we're going a little bit backwards. The most recent data suggested that younger women and women of color are actually less likely to know that heart disease is the number one risk than they were just a few years ago. So, there's no time to say, okay, been there, done that, but we really still have work to do, especially with younger women.
Interesting. So a Go Red 2.0 is almost in order for a younger population. Pavitra, please do your magic.
Yeah, sure. So Stacy pretty much covered it all beautifully. I guess to your point, David, for Go Red 2.0, I would just advocate that moving forward, we need to add more psychosocial stressors and screenings for those aspects as part of the kind of awareness campaign as well. We know a lot of the science behind sex-based differences and the vascular and endothelial responses to mental stress. So we know that on like a granular level, we know that on like a basic science level, but actually translating that to the general public and to help, with stress coping mechanisms and things like that. And the importance of that, I think, should be part of what's to come in the next few years.
Well, thank you. And, it appears to me, quite obviously, that we've got an enormous amount of work to do. Enormous, right? And so this begs the need for broad-based collaboration in order to achieve our, our health-related goals and, a vision for a world of longer, healthier lives. Now, before we move to Q&A, I'd just be curious to hear from the two of you. what comes to the top of mind for something that we can do first as individuals, right? Because we need to take care of ourselves in order to be a benefit to others. So that first, but at the same time, what are some kind of really innovative strategies that you've seen for implementation at the community level? Because ultimately, what we're asking people to do within the sphere of heart safe communities is, you know, although 12 of the 13 criteria really focus on acute event and resuscitation, category 13, criteria 13 opens the doors for primary and secondary prevention. So, what could I do as an individual? What could we do as a community to help enhance overall health and address primary and secondary prevention specifically?
Well, I think we don't have to reinvent the wheel, right? So we have these beautiful campaigns and ways of really trying to remind ourselves of messaging that can help us lead better, healthier lives, right? So I'll put it in the chat, but the AHA Simple 7, right, the pin that I'm wearing, about, living, tobacco-free and eating better, moving around more and managing blood pressure, all of the, I can't remember all 7 off the top of my head, but so, things like that. So just reinforcing those concepts, I think, is something you can do on an individual level. I also think the other useful tool that AHA has put together is the You're the Cure network, right? As a way to really be able to communicate and advocate, with your legislators and organizations around you who can make policy decisions and move that agenda forward. So I can put that in the chat.
Excellent.
I think,
Excellent. You're the cure. That will most certainly be in the follow-up message to everyone. Thank you for bringing that up, Pavitra. That is a very effective tool for advocates, without a doubt. Thank you. Stacy, what would you add?
I think on a personal level, and I love the way Pavitra said it in those 3 buckets. I think in the personal level, the most important thing is identifying a primary clinician who can become your partner over a lifetime, and then starting on the road to what I need to know about myself, my family, and what are the things that I can do, within constraints of I work at night, I can't, exercise as well. Maybe it's harder to eat, so that really you customize the clinical care that individuals get. But secondly, I think really being of the community, so that, what's going to work in one part of Manhattan isn't necessarily going to work in another part. So there's an amazing foundation initiative that started out of New York Presbyterian at Columbia, that partners with rap music to teach young Black students about the dangers of salt. And they've made these amazing videos, and the physicians look like the community. The platform they've used is respected in the community. So I think really, as we've all said, partnering and aligning with existing resources that every city's different, every rural community is different, and finding where those sweet spots are to really have the maximal implementation impact, I think is my dream, honestly.
I think it's all of our dream.
Mm-hmm.
And, I'd pause for a moment and just say the two of you have been absolutely remarkable. Just absolutely fantastic. Great conversation. I'd like to open it up to a few questions. Mallory, would you please do us a favor and select a question for us?
Absolutely. So we had a question come through. What other related conditions to cardiovascular disease impact women disproportionately?
Oh, that's a great question, because it gets me to talk about my favorite newish partnership, and that's between OBGYNs and other either cardiologists, emergency medicine physicians, clinicians, etc. Because the vast majority of women from age 15 to 40 have one doctor, and that's a gynecologist. So we know that adverse pregnancy outcomes, what happens in pregnancy, shouldn't stay in pregnancy. And that often identifies a cohort of women who are at higher risk for cardiovascular disease over a lifetime. Even if the high blood pressure during pregnancy, goes away after delivery, or the gestational diabetes. So adverse pregnancy outcomes is a huge, disproportionate, but only for women. Things like lupus and rheumatoid arthritis and collagen vascular diseases disproportionately hit women. And as Pavitra said, anxiety, depression, sleep disorders, all are more of whammies for women.
And I would just add to the list, unfortunately, but even intimate partner violence and childhood trauma and events like that are more elusive to us. They occur behind closed doors. We don't necessarily pull them out, or they don't come to the forefront, and they happened a long time ago maybe. But they triggered this cascade of stress-induced, catecholamines and other inflammatory markers that then down the road, later on in life, can cause cardiovascular disease. So those are also disproportionately affected in women. Yeah.
Amazing. It seems to me that escalator may be impossible to stop, but we can certainly
I don't want to be a downer, but
no.
we can slow it down an awful lot. Mallory, would you be so kind as to select another question for us?
Yep. So we've got, are there new strategies born of COVID that we could actually leverage to improve healthcare for cardiovascular disease? Or are these ideas just likely to exacerbate disparity?
I think, this pandemic has definitely highlighted and brought to the surface a lot of systemic issues, areas for improvement, but it also, I think, highlights even the power of just telemedicine, right? The connectivity that we can have, as Dr. Rosen said, with our primary care providers on a much even more accessible basis. And so those are the type of lessons I think we need to hang on to as we move forward, to say, hey, we shouldn't stop having telemedicine availability for our patients just because the pandemic is over. I can't tell you how helpful it's been even in my own family on a personal level, to just have that ability to connect, whether it's with your primary care physician or even mental health providers, right? That you don't have to budget an extra hour to commute to go and see someone. So I think that's one lesson that I think we need to definitely hang on to.
Yeah, excellent points. Mallory, let's do one more question and then we'll wrap it up.
Okay. With all the stress and anxiety of the pandemic, how can people improve their mental health?
Oh, it's a great question. And it's interesting, taking on with what Pavitra just said. We have a psychologist who is part of our Women's Heart program, and she is even paid on a grant, so there's no fee to the patients. And, part of the challenge with behavioral health is that it's often outside the traditional insurance plans and scope. And then people still see behavioral health issues as being somehow different, that, I'm embarrassed, I'm this. So what's interesting is that our behavioral health component has actually gotten busier because of telehealth, that people who are embarrassed to go to our doctor's office are now happy to do it on the phone. And we run an integrative medicine studio, for instance, and we've pivoted everything to virtual. And because it's virtual, it's free of charge. And so we do daily meditations and daily yoga. So again, sort of, somebody said, don't waste a crisis. some of the things that
Yeah.
we had to pivot to, including telehealth, group classes, different ways to do education, I think should stay. When do we get back to normal? Well, this is going to be our new normal, because if I could get more people to see my psychologist, then that's a win. You don't have to ever go to her office. If you can all do yoga or a meditation during the day, free at home in your pajamas, great. But I also remind people that these are medical conditions like high blood pressure and diabetes, and the need to seek professional help is not something to be embarrassed or shy about. And all of our health systems have these opportunities available. Nobody
Yeah.
would be embarrassed to treat their diabetes or high blood pressure.
Right,
Well
absolutely.
stated.
The stigma around, mental health definitely needs to fall to the wayside. And I think this pandemic is actually allowing that to be much more accessible, to people recognize the benefit that they can gain for them individually, and then that translates to their family, when they're able to take care of their mental health.
Ladies, doctors, that was extraordinary. Thank you so much. On behalf of the Citizen CPR Foundation, I extend heartfelt gratitude for your sharing your time and expertise this afternoon. I'm going to wrap things up here. So let me just share here, a little more share. I figured this would be perfect for today. Some of you might recognize this fellow. That's Paul Dudley White. I believe the photograph was snapped during a snowstorm in 1958, where he's actually shoveling a portion of Storrow Drive leading up to Mass General Hospital. And he's got an important message for us here. Take care of yourself, right? Your body. It's the only self, it's the only body you got. And so, I salute Dr. White for all the things that he was, including, an all around terrific guy by all measures that at least I can see. So let's see if I can get this to advance. Hey, everybody, I do this every month. We love to have your feedback. Let us know of your ideas. If you'd like to be on the show or know somebody who, would like to be and has an important message and things to share, please do let us know. And then again, all of you be on the lookout for the follow-up email message from us. We promise to include some additional resources for you. And we're grateful for all of your participation in today's webinar and your collaboration around improving health and outcomes. To our doctors, our panelists, again, I salute you. Thank you so much. Laura, I see you out there. Thanks so much for your help. Mallory, thank you. I hope everyone has an absolutely terrific evening, and we hope to see you next month. Till then, ciao.
Thank you. Thanks for having me.
Our pleasure.